you. Could I thank Phil and Kevin for that presentation? I certainly thought it was informative, but more important, I think it was open and transparent in terms of outlining the challenges that we face. The next half hour is question and answer time. It's an opportunity for a bit of participation. It's an opportunity to ask the panel any questions or make any points that you would like to make following the presentations. What I'll do is I'll ask people to raise their hands if they'd like to make a point or ask a question, and I'll do the roaming around bit with the microphone. So over to you. Could we have the first question or point, please? Thanks.
Don't normally need one of those.
Hello, my name's Paul Lindsay. I'm here from sunny Cornwall, and actually very much involved in the STP down there, so I thought I'd come here and have a look at what's happening. We all know that you're far more advanced in your delivery of what's happening than we are in Cornwall, and we're looking to, pinch some ideas that you've come up with. I mean, for the half hour I've been here, so I'll just have a look at this for a second, just hold it up. We produced one of these as well. It's not really all like yours. So think of the cost that's involved in two next door to each other's duchies and counties that have produced a different document and cost. So that's just one point I'd like to make. In there is also, you've identified priorities. And this isn't a very small point, but think about it. Priority 1, priority 2, priority 3. Now, is that priority in terms of what you're looking to achieve, or is it just a number? I would have thought it would have been better to have priority A, B, C. It's just a small point. We've got these targets that are being hit with us from above. Now, I wonder whether the guys that are, people that are actually working at NHS England are actually boxers. Because all the senior execs that I've talked to can't get through that organisation to say, this is the problem we're all having. I mean, even the MPs are now very much frustrated that what's being achieved is hard. We're not being successful. Your presentations was very good. I mean, you've got a lot of the great points across, but it's breaking that barrier. That's what you're struggling with. And I don't know, other than you putting the notice in and everybody's resigning, that's going to say, we need investment. You can't start any project without money. And if you're going to make the savings of £500 million, then you've got to put some investment at the front end, and we're all struggling to see that money trickling through. When I talk to my KCCG people, they're struggling as well. So I haven't got an answer for it, but it does need some trickling of money coming through to start some of the things to make the savings at the back end. And we don't even know what those savings are going to look like at this point in time. I've got a lot more to say, but I'm going to hand it over to other people.
Okay, thanks. I think that was 3 points for the price of one, actually. Would the panel care to respond to any of those particular points or issues that have been raised?
Well, I'll do two things. First of all, I've worked in Cornwall for 4 years, and I pretty much know if someone from Devon wrote a plan for Cornwall, that wouldn't be well received. So I think it's important.
Not writing, but working together.
Anyway, we might do it collectively, but I think there is something about local determination, local priorities, and areas sufficiently big enough, so a population of 500,000 in Cornwall, then services should be able to set their own plan out. I think in terms of the NHS England issue, the STP is an opportunity for us locally to set our priorities and to set our direction of travel to try and deal with those without upward interference. Of course, there will always be a watchful eye, but I think the STP does give us the opportunity to try and deal with the issues which we want to try and tackle, and perhaps move the emphasis away from the day-to-day grind of trying to deliver the national standards, which are important. But in terms of the things that we've identified here, these are real live issues in Devon that we want to try and address. And I'm sure colleagues in CCG have done exactly the same.
I think the other thing is in relation to, I I spoke to the medical director down in Cornwall at the Acute Trust, and I think we're trying to engage with them because I think they realised that we kicked off with the success regime. It gave us quite an infrastructure in terms of assessing our system, our ability to run the workshops, which has pushed us well ahead of many standard STPs. And if you actually look at the other success regimes in Cumbria, and I think they're in a similar position. Big kickstarts, we're well advanced, and we're more than happy to share any of the data we've got with them, and actually to welcome them to the clinical cabinet or any of the other meetings that we would hold. And I think we're quite keen to do so.
Okay, thanks.
Can I move on? There's a couple of hands up here and then one there. Let's start with you.
A bit like the gentleman who's just spoken, I've got quite a lot of different points. I'm also aware that I'm not able to offer answers to what I'm saying, but I feel that we talk about integration, but there still isn't the money in areas where there is integration to make it work well, basically around care in the community. Care in the community has to be set up with quite a large amount of money in a robust, safe and effective way if it's going to work. Because if it's not set up in a robust, safe and effective way, it will simply end up with further hospital admissions. So we're talking short-term savings ending up in long-term cost. Because hospital, as the points have already been made, hospital stays cost an enormous amount of money. Therefore, it's far better to keep people at home and treat them at home. But you can't do that if you don't have that system working well. Secondly, regarding things like lack of staff, the points that were made about the number of GPs that are going to be lacking, the number of consultants that are lacking, poor recruitment, no availability to be able to recruit. There are two things here. One, all these things were known some time ago, and when I say some time ago, I'm talking years back, when all the cuts were brought in to reduce the number of training places, to reduce the number of staff employed. It was envisaged then that we knew that we would reach a point in time where GPs would retire and there wouldn't be enough people to replace them. Why are there so many agency workers, which proves that there are trained people out there, but they're not actually being effectively employed within the hospital services? I find that really frustrating. There are the people, they're just not being employed in the right way. And again, the other point that gentleman made about targets, I worked within the NHS for quite a long number of years. And when I first started working for the NHS, we didn't have such things as targets. We gave care. Now, targets, I think, are negative. Not only do they add to the pressure of the poor numbers of staff that are already working, but they also end up producing poorer care and a lot poorer morale. Now, like the other gentleman, I could make a lot of other points, but I'll leave it there.
Thank you. Once again, that was not even on the in terms of numbers of questions or points you made. Can I ask the panel if they'd like to respond to any of those points or issues?
So, yeah, I think you make some very good points on all three of those issues. Coming to the integration, I agree, integration, to make integration work, it needs investment and resource. Integration needs investment and resource. I think one of the successes locally within the Western system has been a willingness to pool budgets, and certainly in my experience as a GP working in the South Hams part of the Western locality, there has been a willingness to pool social care and community care budgets to provide joined up care so there are no handoffs between agencies, and that's a model that I would support and advocate moving forward. Your point specifically about locum costs, we are in a system where there is an internal market. That's a system with which we have to work. Certainly as a GP partner in an organisation, I would absolutely love to be able to appoint substantively to vacancies. The reality is the market deems that quite a lot of newly qualified GPs prefer to locum in the short term because of the financial incentives. Now, that's the system that we're in, and sort of rightly or wrongly, the workforce strategy group within the STP is looking at just this and looking at the perverse incentives that exist, but we have to work with the market that's there and take steps to measure as we move forward.
Just a couple of things from me. Just in terms of the agency staff, again, like those, we'd love to employ more doctors, but there are many, and nurses indeed, who prefer a lifestyle which is slightly less certain for them. Of course, they get paid substantially when they're in agency positions, but that suits the way that they want to work. So, as Steve has already said, those are real live issues that we're trying to deal with. I think in terms of the point we made about integration of care, I think there's a really important point that we do need to address, and that's around giving care providers much more certainty around the types of contracts that we give with them. It was in the news again earlier this week, wasn't it, around care providers not being able to carry on just because of the amount of money and the length of contract that they're given just doesn't allow them to provide a sustainable, high-quality service. And then the targets today in my life, but they are important. And if you take the emergency department, there's very good evidence that if you wait a long time in the emergency department, that your outcome deteriorates. So whilst we all struggle to meet the 4-hour target, and some would say it's a bit arbitrary, but actually if you wait arbitrarily in an emergency department for a long time, it's not good for you. So we need to do what we need to do to try and deliver some of those statutory, remember they are statutory standards.
Thanks for those responses. I think they were good points, and certainly the points about integration and workforce, I think, need to be fed back throughout the STP. But the lady here had a question.
It's really picking up a bit on what the gentleman from Cornwall said, but also some points you'd made yourselves about the need to work smarter, to look for more efficient ways. People in the video actually commented that there were better ways perhaps of working and doing things. I think there's been enough in the press as well to look at the shock horrors of how different parts of the NHS have bought things or at different costs. If we're number 37 or 38 STP, there are all these others around the country, some with some very similar rural locations such as ours, I'm thinking up in the north. Is there anything happening in terms of sharing knowledge, looking at practices to stop things being reinvented and perhaps joining forces?
Yeah, I think if you look at the integrated community piece that's gone out consultation in the East, we looked at Carmel Farah, who actually supported that particular project, looked at many of the different new models that have been implemented across the UK. They looked for the benefits, they looked for the various challenges intrinsic in those models. So there was a lot of reviewing of other models around the patch. We've also, if you look at the maternity piece, which has set certain challenges, particularly around North Devon, and compare and contrast against Cumbria, where they've got a similar geographic location. But if you look at the North Devon Link Road, and you then compare that with the link road between the two hospitals in Cumbria, for instance, there's 25-30 minutes between the hospitals in Cumbria, there's an hour and 10 minutes between Barnstable, Royal Devon and Exeter on the link road. So we're looking at all of the other success regimes and the early outcomes and I suppose ideas they've come up with. I have to say we're in the vanguard and people tend to look at us because we're moving faster than anyone else. But certainly where there are integrated models, we've looked at other integrated models, and where there are other areas in relation to, for instance, the urgent services, we've looked at modelling in Europe, Australia, America. We've compared and contrasted most of the novel models of actually working smarter, and we've pulled any of the best pieces and ideas from those models into the scenarios that we're currently working on.
So I've got two other points to raise. First, in terms of that procurement that you raised right at the beginning, there's a whole load of work going on under the sort of the banner is called Carter, Lord Carter, the Minister, and he's championing standardisation and consistency of processes and systems within hospitals, but also very much part of that will be procurement. And we've done a lot, particularly at Derriford, I talked to the other hospitals and them about that. There's also, in terms of clinically, there is a project called Getting It Right First Time, and that started in orthopaedics, where a professor of orthopaedics at Oxford toured the country and looked at all the orthopaedic departments and has made a series of recommendations around how they can benchmark against each other and can better work. And that is now being rolled out across all surgical specialties across the country. So that will drive a huge amount of consistency in terms of approach and also best practice. So it does allow us to benchmark against others.
Sorry, a follow-up point.
Is there any way that you're going to let people know about that referencing so that the wider population can understand what's been happening? Because otherwise we just get a particular picture and don't necessarily know some of that background thinking that could help us make our decisions and make our points more clearly.
Yeah, okay, so I'm pretty certain colleagues here will make sure that people are interested in the Carter work and the Getting It Right First Time work. We'll let you know how you can find out more information about that. And certainly, if you ever come to any of our board meetings at the hospital, and we do talk about those things a lot, but obviously it's everyday language for us, so again, we could perhaps signpost you around our agenda, and our agendas and minutes and board meeting papers are on our website. But I'll look to the colleagues who are facilitating workshops to try and get some information out about that.
What recognises the point about communications. Thank you. Gentleman at the front has a question or point.
Thank you very much. Good morning. Richard Hossinger, Devon County Councillor. You'll be pleased to know my list has gone down from 3 to 2. The first question is, we are undergoing the process of STPs and at the same time an acute service review on 3 areas within acute hospitals. One of the big concerns in Devon County Council, or in Devon, if you like, is the closure of community hospitals, which may result from the STP process. And the question is, would it not be the correct thing to actually undergo a complete acute service review rather than just 3 areas at this moment to establish whether, in fact, we could utilise some of the resources that may be closed for the better provision of acute services throughout the county? That's my first question. The second is with regard to A&E units within hospitals. There's, again, a lot of press comment on this. And it seems that the introduction of the 111 service, I think it is, has actually increased the number of people now making their first point of call for diagnosis at A&E centres rather than GP practices. Is that, in fact, an efficient use of hospital services, or should we be seeking to divert people more to their GP practices? Thank you.
Thanks. Good points. How would you like to respond?
Well, I'll take the first one to start with in relation to the acute services reviews we're talking about here in relation to their relevance to the community hospitals. In essence, they don't have any direct relevance because if you actually look at the emergency surgical, emergency medical, and the type of patients coming to the ED and maternity services and then stroke, none of the community hospitals are appropriate to manage those particular individuals. If you actually look at the sorts of services and consultants and nursing staff we need, there's a challenge as to whether some of the smaller hospitals currently in Devon are capable of doing it themselves. So what we can't do is actually try to put services in even smaller hospitals, which to a certain extent would disadvantage the patients that were admitted to those hospitals. So I think if you look at the community hospitals, the issue in relation to community hospitals probably has more relevance in relation to the bed-based care and the step-down coming out of hospitals. Where should patients be managed? And ideally, the best place to manage a patient is in their own home if you can do it. And I think certainly the other piece of work that went through the consultation in East Devon looked at how many beds do you need in a community in any given region of Devon to actually appropriately manage the sorts of patients as they cascade down back into the community. And I think there is a number that they're actually working to, but that particular number is something which has been modelled based around the patients coming out, some going into the system, but does not directly relate to the acute services review, because none of the patients potentially in this particular process would directly be admitted into those particular facilities. Is that reasonable?
Just one other thing to add, I think there are also significant staff shortages in a number of community hospitals. So I don't think there's a huge workforce that could transfer into the acute setting. But I think what we need to do, if there is a workforce that can transfer, then as Phil already said, if that can help support people in their own home, then that's certainly a great benefit.
So I'll take the point back. Hello? Yeah. I'll take the point about the 111. I think obviously the 111 was a national rollout, and I think clinicians have been very involved from the outset in trying to look at some of the issues that the 111 rollout brought. I think clinicians on the front line recognise that there have been some peaks in activity caused by 111, and certainly in the local system, steps have been taken to mitigate that and get people seeing the right person at the right time quickly. And so we have looked at how the out-of-hours GP service is configured and how calls are handled. So steps have been taken locally to make sure that there is earlier expert advice. I think the principles behind 111 were good. I think it's recognised that the implementation led to some undesired consequences which have been mitigated locally, but it's still under very close review. Any sort of algorithm with emergency and urgent care needs to be safe, and I think the need for safety initially led to rather more people going to ED and a disposition than to their GP or to an out-of-hours emergency practitioner. So my perspective is that there were some issues and that some lessons have been learned, but the situation is improving and has improved since some of the steps have been taken locally in Devon.
And I was involved in when we were doing the consultation piece on the integrated model of care. I think there is a model that everyone is endeavouring to apply, which is a single point of contact, which would then signpost people to a rapid response team. That rapid response team is 24/7, because I think one of the problems that certainly general practitioner colleagues made was on a Friday evening, when you've got a patient that's unwell, general practitioners trying to work out whether or not there's a healthcare worker that can look after them at home. They can't get hold of that healthcare worker, so the safest place to park them is in the local emergency department. So we then get a patient that we don't know at all. They probably could be managed at home. There is no care plan for them that we're aware of, and they get admitted and they stay with us for the next 7 days. Whereas if there's a rapid response team that are aware of the care plan, they know what the care plan is for that patient, the wheels come off the wagon, they can actually manage them in an appropriate setting. So I think that is the plan alongside the new integrated model of care, the reduction in community beds, and allows that to be implemented safely. That is something that Wilkinson Bryce, who is leading the implementation in the East, has also been challenged to ensure that in the West, Plymouth, that the resources we have and the pathway that has been agreed in the East is implemented in an equivalent fashion right the way across the patch, so that the model is fair to all in Devon, and I think we will benefit from that.
Okay, thanks. Really good questions. I've got one more point or question, I've got two more, and then we'll move on to the next session. It's yourself first.
It seems to me that basic problems within the system lie at the very beginning and at the very end. In other words, with primary care and with social care. And so it would seem to me that the emphasis has to be on improving both of those facilities. More GPs that should be more accessible and more effective in the way that they are able to treat patients, and then after patients are discharged for mental health, starting from patients even at the age of 5, because we are seeing greater numbers of young children with mental health issues. And so again, there has to be the emphasis on both mental health care and on primary care. I don't know whether any resolution has come to this, but we were given some information at the beginning that life expectancy in postcode PM1 is 10 years less than in the Ivy Bridge area. So I do wonder why a very successful and very empathetic GP practice in PM1 was closed on March 31st, or will be closed on March 31st. I know that there are economies of scale, but a practice which was treating the most vulnerable people in Plymouth will cease to be. And a tiny point on communication. On one of the slides, the statement was made, the best bed is your own. I actually find that statement quite frightening, because the best bed is not always your own. Sometimes the best bed is one in critical care, or one in the acute hospital. And I think we need to make sure that the public do not misunderstand and become fearful that what you're basically trying to do is to close down the provision of care in acute hospitals.
Thank you. Once again, a number of points. Panel, would you like to respond to the points that were?
I think you just covered the STP there, most of it. I think you've got healthcare prevention. There is a healthcare prevention stream which identifies that there are massive inequalities, particularly in some of the more deprived areas of Plymouth. I'm sure we will talk in a minute about why certain areas have been closed. I think in terms of best bed, I think a patient, if it's appropriate, the patient's in an intensive care bed, they should be in an intensive care bed. They should, when they're ready, if they're in an acute bed, they should be in an acute bed. But when they're ready to go home, and they should be an appropriate resource to support them in the community. There's no doubt that they stay in hospital beds, the degree of debility, muscle loss, and their ability to get out of hospital is significantly diminished. So when it's appropriate, they should go home. But I do take the point, and I think that's something that we have discussed. The message can sometimes look rather one-dimensional in terms of you're just trying to get rid of hospital beds and put patients open to the community when it may be inappropriate, and that's not something that is intended. In terms of, it's obvious where the problems were in general practice and obviously out in the community where patients need to be supported. I think the community integration piece actually certainly does look at supporting patients in the community, the reallocation of various healthcare workers, and that is something that, particularly in the East, where they implement this, there is an implementation plan which will not allow them to close beds until there is appropriate resource in the community, which will assure commissioners and patients that they're ready to throw that switch. General practice, major issue. There is a particular work stream within the STP which is looking at how that will be addressed in the future, because we know in Plymouth there is a massive deficiency in terms of general practitioners, which has been alluded to already. Obviously, in the middle, we've obviously talked about the acute service review today. It doesn't touch any of those areas, but you have quite quickly sort of rounded up many of the other areas that probably Nick is aware of that we've been discussing at the STP, which, as it were, circle the acute service review, because the acute service review does indeed identify substantial issues, not just in the community, but actually in the acute trusts where there aren't enough doctors, there aren't enough nurses, and I think it's having an impact on the quality of service and potentially in some areas the outcome, more importantly, the quality of service across all zones in Devon.
So I totally agree with your opening point about primary care and social care being the most important parts of our system, or extremely important parts of our system. My view is that high quality primary care is the bedrock of the NHS. So if we get that bit right, we get the whole system right. Just building on the point, primary care to me is more than just GPs. So GPs are clearly key players in primary care, but primary care includes community nursing teams, it includes pharmacy, it includes opticians, it includes dentists. There's something for me about how we configure primary care so that it's fit for purpose moving forward. Because actually a lot of traditional general practice within primary care hasn't changed a huge amount from when it was first formed back in the 1940s. So that, I think that's an important point about how we look at meeting the needs of the population in our city and in the wider Western locality. The particular point about practices or practices closing within Plymouth, beyond the scope of today's conversation, but NHS England, who are the commissioners who are responsible for commissioning general practice, I know have worked extremely hard within the city and further afield in the Western locality to try and find people to take over the contracts. GP practices, by and large, are independent businesses who can, if they choose, hand back their contracts. So there's no intention to shut practices from the commissioners, but some GPs elected to hand back their contracts. And so the duty of the commissioner, as part of their system, is to work very hard with other neighbouring practices to make sure that patients' needs are met.
Okay, thanks. So very good, but whole system points. I'm going to take one last question before we move on to the next one. So, good to you.
I represent the patient participation group, and we hear a lot about the need for patients to take more, people to take more ownership of their health, which is fine. I suppose got 2 points. A point really, is enough being done at the moment to help patients and to educate patients? Are there any new initiatives other than endless leaflets and posters we see on walls, which get more and more dog-eared and basically don't get read? So are there any new initiatives planned to help patients with this important thing of patient education?
Very good point. Would the panel like to quickly respond to that before we move on?
So, Fred. Hello? Yeah, that's right. So prevention is a key priority within the SCP. I think on a practice level, I know my own practice are really keen to understand how we can promote both self-care and early intervention as part of our patients. So we're working with our patient participation group to look at sort of appropriate forms, whether that's using social media, whether that's using some of the new technologies which are out there. So I think there is something on a practice level that needs to be done, but I hope and expect that the SCP will look at this as part of their prevention work stream, because I think actually we need to be promoting early intervention and self-care far more than we have done historically. So I think it's a very good point.
And I think in some areas, if you actually look at some of the data, if you look at stroke, the presentation of patients with stroke is delayed frequently in North Devon. And also at the moment, if you look at the resection rates for bronchogenic carcinomas, there's considerable variation from the north and the south by comparison to Rondell and Exeter and Plymouth. And I think we've looked at that, and I think they all go through the same workshops, they all have the same surgeons. So there are a number of different issues where I think the directors of public health who head the prevention work stream need to look at some specific areas, but there's no doubt actually reaching out to some of the populations in some of the more rural areas is very important, because I think there are a number of messages that probably would benefit those populations greatly, judging by some of the data we know.
Can I thank everybody for those thoughtful and articulate questions. We're going to move on to the next part of the session, and we're running about 15 minutes late because of my bad timekeeping, I'm afraid. But the next session is tabletop discussions. We will put the questions already up there, and they are in the packs. On each table there should be a facilitator who will help with the discussions, and most importantly will record the discussions and the key points, and those will be fed back to the CCG and all the participating organisations that you saw. So without further ado, if everyone could join a table, we look forward to tabletop discussions, and I invite the panel to roam around the tables and sit in and observe.